Hello, and welcome to the latest edition of Health on the Line, produced by Health Comms Plus on behalf of the NHS Confederation. We and our members have been waiting with eager anticipation for sight of the Model Region Blueprint, the document that will set out how the English regions will be managed in the future and what that means for ICBs and providers alike. It's an important document because without sight of it, members are unable to move forward with their planning. With me to discuss the implications of not yet having the model regional blueprint is Sarah Walter, Director of our ICS network. Welcome to Health on the Line, Sarah.
Thanks for having me, Matthew.
So, some people will know all about this issue, Sarah. Others will have no idea at all. So, can you bring us up to speed on this question of the model region blueprint? What is it, and why is it important to our members?
Yeah, well, I'm sure all of our listeners will be aware that there's significant change going on within the health service at the moment. We've seen announcements earlier on this year about changes to the centre, NHS England um, becoming absorbed into the Department of Health, and a cost reduction, a headcount reduction of around 50%. ICB, so integrated care boards, also told in the spring this year that they would be expected to achieve a cost reduction of 50%, and changes also to providers. And so lots of change within the overall NHS operating model, of which the region is an important component. Um, and we've seen a lot of activity, I think, underway, in particular in relation to integrated care boards. ICBs have been part of developing the model ICB blueprint, which was published at the beginning of May, a process led by Penny Dash at NHS England. And in parallel, work has been underway on the model region, which is a really important component of this operating model. ICBs already work really closely with the region, as do NHS trusts and providers across regions. And so understanding how the regional component of the new operating model is going to work is a really important dependency for all the other parts of the system. The original expectation was that that model region blueprint work would be complete by the end of July, and we understand that work was largely complete by then. But we have yet to see a final kind of published document that ICBs and providers can use to support their own planning and think about their functions and their way of operating in the future. So it's an area that I know many members will be keen to see and engage with as soon as NHS England are in a position to release that.
And do you have any sense, Sarah, of what is the cause of the hold up?
I think, clearly there's been a need for engagement. The regional component has an interdependency and a kind of interplay with ICBs, with providers, and also with the centre. And so I think, there's clearly a desire from NHS England and the department for that regional layer to benefit from those kind of connections, and really kind of make sure that it works in the context of how the new centre is going to operate as well. And we know that those conversations are live right now. Richard Barker is leading that process of change for the centre, and the regional component is an important part there. So we understand there's discussions happening between NHS England and the department in particular over the summer. And we're hopeful that we'll be able to see something soon. But certainly our members are pushing for NHS England to be releasing that blueprint as soon as is possible.
Yeah, and Richard Barker is clearly, couldn't choose for a better person to be overseeing this process. And from what I'm hearing, Sarah, it echoes what you're saying, which is that this is partly got wrapped up in this question of the NHSE moving into the department. These are NHSE regions that will soon be departmental regions, and those are rather different kinds of things. It also kind of picks up differences. I hear, when you talk to people in the department, they talk about NHSE being subsumed, abolished, being subsumed in the department, whereas in NHSE, they tend to talk about merger, and they tend to point out that there isn't yet an absolute date at which this is going to take place. So there are differences, but what impact does it have on our members, in particular ICBs, the fact that we don't yet have this regional blueprint?
Well, I think ICBs, there'll be a certain degree of frustration, I think, given the pace at which ICBs have been required to pull together their plans. So, they're the model ICB blueprint was published at the beginning of May, and ICB's had until the end of May to submit their first cut of cost reduction plan. So how were they going to change their organisations in order to deliver that model ICB blueprint? We know ICBs have been in discussion about clusters and mergers, and that is all progressing at pace. But there's a really significant interdependency between how ICBs operate in the future and how regions operate. The model ICB blueprint lists a number of functions which are anticipated to move to the region. And I think it's quite difficult for ICBs to kind of plan their future design and how they're going to operate without also understanding how regions are expected to operate and being able to kind of develop that ICB plan and how it's going to kind of dock into the new regions and their way of working. So there is a kind of, I think it does add an extra layer of complexity into what is already an incredibly complex situation for ICBs to manage.
Yeah, and this affects, of course, the capacity of anybody to deal with what are, challenging issues, but also areas where there is potential, given the financial constraints we're under, to think about how we could do things better. So, for example, continuing healthcare, well, we know there are huge variations one part of the country to another, difference in the kind of criteria for accessing that, which has a big impact on patients, kind of postcode lottery, safeguarding, where I think there's a sense at the centre that potentially more money has been spent on safeguarding that needs to be could be potentially rationalized. We need to be clear about what it's about. But I just want to focus just a little bit, sorry, on one other issue, which is around kind of emergency planning. That's a function, as I understand it. You'll correct me if I'm wrong. That's kind of slated to move from ICBs to regions. Now, winter, I go swimming in the mornings. So for the first time this morning, so cycling across York, my hands felt cold. So winter is starting to come, and that's when that kind of capacity emergency intervention is particularly important. We do need to sort this out ahead of winter, don't we?
We do, although there has been some clarification. So some FAQs were published back in June. So this is after the model ICB blueprint was published, saying exactly that. So some of these functions that ICBs have historically managed, in particular things like EPRR and things like system control centres and managing winter. So the FAQs published in June clarified that ICBs will continue to hold that responsibility for this winter. Each ICB has been told to nominate a winter director. They'll remain accountable for that EPRR function for this year. But how this works longer term is clearly an important question. And even in the short term, there's clearly significant change underway in ICBs with their cost reductions and the potential redundancies that may flow from that. Although, I think as we've described in previous episodes with Health on the Line, and certainly have been talking about within the Confed, those restructures themselves are also at risk given some of the questions still about redundancy and how those financial costs will be borne. But I think that, I guess, one of the principles around all of this is trying to have clarity in the midst of complexity, and that clarity continues to not be forthcoming while we're waiting for big parts of this jigsaw to be confirmed.
Yes, well, I think we can say in summary, can't we, that ICBs continue to find themselves in a situation of doing their best, preparing for winter, but not really being supported in undertaking the changes they've been required to undertake, and that colleagues at NHS England and the department are coming back from their summer holidays with a pretty big and urgent in tray. Sarah, thank you so
Lovely.
much for joining me.
Thanks for having me. All right. Thanks very much.
Now, the ambulance sector, some say, is the canary in the coal mine, signalling first when the NHS is coming under pressure. Ideas for how to address the ambulance sector's many challenges features in both the 10-year plan and the UEC plan. And so we thought, who better to address these issues than representatives from the ambulance sector itself? So we're delighted to be speaking to Anna Parry, Managing Director of the Association of Ambulance Chief Executives, or AACE as it's more commonly known. And we're also really fortunate to be joined by two Ambulance Trust Chief Executives, Simon Weldon of South East Coast Ambulance Service and Dr. John Martin, who's based at South Western Ambulance Service. I'm really pleased they're able to join me this morning. Welcome, Anna, John, and Simon to Health on the Line.
Thank you.
Thank you. Good to be here.
Uh, Anna, let me start with you. um, getting your take as MD of AACE, representing the ambulance sector, on what you think are the kind of major implications of the 10-year plan for the ambulance sector. Does it go far enough in mapping the future of the sector? What's your kind of general view of the 10-year plan?
Thank you, Matthew, and thank you for the opportunity to join you this morning. So, we really welcome the publication, the 10-year plan within the ambulance sector, ACE, and within our wider membership. It outlines a clear vision of the NHS of the future. We welcome the ambition and very supportive of and in agreement with the three shifts. We published a vision last year, a vision of the ambulance service of the future with the NHS Confederation and providers, which very much aligned with the aspiration outlined in the 10-year plan. As we all know, the focus is very much on neighbourhood health. Ambulance services operate on a regional footprint while interacting, of course, at a neighbourhood level too on a daily basis with patients. But there's a sort of potential risk for us there. And a job that we've got to do is ensure that the excellent work that ambulance services do at a regional level in relation to call taking, call navigation, clinical triage, and so on, supports the realisation of the plan and the delivery of much more healthcare where appropriate at a neighbourhood level. We're delighted that we've got a voice on all NHS England's 10-year plan work streams. We've recently depicted how the ambulance service, simply how the ambulance service can support the delivery of neighbourhood health, and want to continue to work with NHS England colleagues, Department of Health and Social Care colleagues, and others to ensure that we're kind of doing our utmost to support the delivery, to ensure ultimately that patients get the care that they need in the place that they need it.
So, turning to you first, John, thinking about the 10-year plan, but also the UEC plan, what do you see as being the key success factors, the key determinants of whether or not things are going to improve for the ambulance service and in terms of the ambulance service's contribution to the recovery and transformation of the service?
Yeah, so I think the 10-year plan really does outline lots of things that we need to do between us. And those of us working in the NHS would certainly realise we're not delivering what we want to for patients right now. And I think that the three shifts that are outlined there, so the analog to digital, the hospital to community, and the treatment to prevention, are all things that we would recognise in practice. I'm sure, like maybe many listeners, when it first landed, I did a quick search for the word ambulance. If you're working in ambulance services, only appears 16 times across the 171 pages, but and 60 of them are in the references. But as you start working through that, you realise actually that we are a key component of the neighbourhood setup. What might be coming in that? I think the big challenge, we've seen a lot of these shifts often framed in another way in the past. I've only ever worked for the NHS in the last 25 years. For me, it's going to be about whether or not we can take the ambitions that are outlined, where the ambulance service fits, where does the paramedic profession fit within that, and whether we can deliver it. And I think you referenced there the urgent and emergency care plan. It's whether we can do it whilst we're still delivering the service that we are. There was a great advert a number of years ago from a software company that was a plane, and the advert on TV was a plane being built whilst it was already in the air. And I think for me, that's the challenge of this plan, is whether or not we are going to be able to make the changes and the shifts we need to make while still flying the plane that is the NHS or the ambulance service in our case.
So, Simon, I'm really interested in how, pick up on what John said. And I have to say, if someone said to me, do you want to take a journey on a plane that's going to be redesigned while you're in the air? I think I'd probably take the ferry. So, in a way, that kind of reflects how challenging this is. Well, what's your take, Simon?
So I think the plan is perfectly encapsulates the kind of great challenges that face us as a country and as an NHS. If I was to highlight one area which I think has to deliver this time, is digital integration. And all of the plans that I have seen, and I've seen quite a few of them now in my lifetime in the NHS, digital technology and what it can promise has always been on the horizon, but has never been fully delivered. And I think we're going to have to grapple with, how do we really integrate all that we know? Patients assume that we know everything about them, and they're always really startled to find out that we don't. And I think if we don't get that integration, we won't get the synergies, we won't get the productivity, we won't get, in actual fact, the improved clinical outcomes that patients are expecting. And I think to resolve that challenge, my take would be we've got to reconcile the kind of our organization's sovereign or our system's sovereign. Because if we're going to solve this, somebody somewhere is going to have to make some decisions about we can't all plough our own furrow. And for us as a sector, we're starting to look at that. We're starting to look as a collaboration of Southern Ambulance Services. Do we integrate some of our digital technologies for precisely that reason? Because we know that to serve patients better, we've got to make a difference in that space. That's my key challenge.
And that's really interesting, Simon. And I'm going to come to you, John, on this first. One of the things, of course, I've realized in my time at the Confed, speaking with Anna and AACE, and coming to ambulance leaders conferences and speaking one-to-one to leaders, has been the challenge of integration often feels difficult because ambulance services work at a different scale to the way in which we often think about integration. So ambulance services work at a kind of regional level and then often focus quite a lot on their relationship in particular with acute hospitals. We'll come on to some of those issues in a moment. But integration is taking place at system level, place level, and now neighbourhood level. The 10-year plan states ambulance services will play a key role in supporting neighbourhood health. That's a quote. But ambulance trusts weren't included in the bidding process for the National Neighbourhood Implementation Programme. So, as I say, starting first with you, John, how does the ambulance service solve this really tricky problem of the kind of scale at which integration needs to take place, which isn't always compatible with the scale at which ambulance services need to work?
Yeah, so down here in the southwest, we cover 7 integrated care boards, moving to 3 clusters shortly. So all of them have got different ideas. We're a key part of each of those 7 systems, working then with 18, 19 acute hospitals across the region as well, and multiple mental health providers as well as police and fire services. It is a really key challenge. I think for us as an ambulance service is focusing at a broad level on 2 different groups of patients. There's those that are an emergency and need a high acuity 999 call. Lots of calls coming via 999, but the high acuity end, where actually the influence of neighbourhood is probably less, and actually you can have a regional response. It's similar whether you're calling from Land's End in Cornwall for us, or right up in Bournemouth or Tewkesbury at the other end. But then there's this big group of patients that often are frail, or other groups might include mental health patients. We know where actually their delivery of their care at a neighbourhood level is what will make the biggest difference to their outcomes, and that's where we as an ambulance service need to be embedded on a day-to-day clinical basis. Simon's already touched on this. There's something about digital here. We see in the 10-year plan a case study from Estonia about how do we access other information systems, and then I think it is into referral pathways, and I think some of them are going to have to be designed with us at a local level. Certainly here in the southwest, I've encouraged that we think about ourselves as part of systems. So that for us has been at ICB level. The question now, I think, is how do we do that at a neighbourhood level as it comes through? Because you're right, at the moment that's very much in its infancy, and we're not at there's so many meetings going on in this space across the southwest. How do we represent that? But I think that's a challenge for us as an ambulance service. About, well, actually, we've does it have to be the executive directors, or can it be further down the organisation? And the difference between providing that really high acuity emergency care, which I think can be done at a regional level. We want a universal service in that space, versus this other big proportion of patients who really a local flavour will be important. But it is a challenge, and it's difficult to work out how that's going to play out at the moment.
See, I think that's fascinating, Simon, turning to you, because arguably one of the vulnerabilities in terms of implementation of the 10-year plan, and it's something we've seen before, is that we don't invest in the kind of organizational development capacity, the brokerage capacity that, as someone once put it, politicians invest in bricks, but they don't often invest in the mortar that is necessary to make those bricks work together to build a wall. And thinking about the ambulance service, there are conversations around the country now around who's going to be the integrator, about IHOs, about multi-neighbourhoods. It's a kind of prosaic challenge, but how do you simply have enough people with sufficient autonomy and seniority to be in the room when those conversations are taking place?
So I think you talked about integration, and one area I'd add to your list of areas where integration needs to take place is commissioning, because I think this actually starts at a level above organization. I think, if you live in the southeast and then you look at our neighborhood, so our neighbor service in South Central, although we are part of the same region in NHS terms, we are commissioned in fundamentally different ways. And that has driven different clinical outcomes. This year, we've actually brought our commissioners together. And so, for the first time, as we start to face into the commissioning round and the 3-year plans that we're all going to be producing from October through December, um, we will actually have one set of commissioners working right across the Southeast. And I think that reframes the conversation. I also think that the other thing that changes in that commissioning construct is things that were traditionally commissioning tasks now need to pass into providers. That's part of giving people more autonomy to make local decisions. And then I think, back to your point, we've got to, as ambulance services, invest in local leadership. So we've just moved in CCAM to a divisional structure. And I'm saying to our divisional leaders, very familiar in hospitals to have divisional structures, not so familiar in the ambulance sector. And I'm saying to those local leaders, it's your job to develop the deep subject matter knowledge of a local area. So neighbourhood means something to people as well. But I'd make a strong plea that we don't forget commissioning and we don't forget ambulance service commissioning, because I think there's a lot that can be gained by reframing that conversation.
No, really important point. Now, I mean, Anna, you see, there you are at AA. So on the one hand, as an advocacy organization, you want to be in the room where the decisions are being made. So you'll recognize this challenge of ensuring that the ambulance service is part of the conversation at neighborhood, place, and system level, even if that isn't the kind of footprint of the ambulance provider. But on the other hand, AACE is also involved in supporting chief executives, other executives in the kind of leadership in their leadership development. So it's interesting, isn't it? Absolutely, what Simon has said, bringing those two things together, that actually for the ambulance service to make sure that it can make the biggest possible contribution to recovery and reform, it is going to require chief executives to build the capability to trust their staff to devolve within the organization, because they simply can't be in all those rooms.
Yeah, yeah, absolutely. And that's been something that has been an issue for some time now in the commissioning space, if we sort of take that specifically, because I think that is so important, as Simon has articulated. We sort of lobbied for number of years ago for a sort of pan ICS commissioning approach that hasn't really been realised in the majority of places for ambulance services. Which is so important because so much of our provision is at that kind of regional level, as John's talked about. A lot of that we would advocate needs to be commissioned at a regional level, with the discussions going on sort of at a place, neighbourhood, local level, where that's required to get the sort of best patient outcomes. I think from an ACE perspective, we've produced a graphic clearly sort of outlined, and this is, people have welcomed this. We've had a lot of positive feedback from within the sector and outside primarily, and that's the important bit really about what our role is, what we can contribute. But identify, Matthew, as you said, we have very lean organisations. They're becoming leaner in the context of the current sort of financial climate. How best can we interact at a national, regional and local level? We recently published our sort of proposed commissioning model, and in that I've talked about what needs to happen at a national level around comprehensive service specifications that enforce minimum standards, so we can ensure, and it's very important to ACE, and of course very important to all our members too, even though they're working in those regional areas, that we're attempting to level up rather than tolerating sort of huge variation, which we do currently see with regard to performance, delivery, and clinical outcomes. So at a national level, have that clear sort of comprehensive service specifications that enforce minimum standards. We would advocate for an enhanced regional commissioning model where you have performance management against those national standards, considering the regional context, considering the financial variability, and as well where we haven't seen that much progress so far, but hope the 10-year plan gives us an opportunity for this, is around better system level workforce development and planning, and moving out of the sort of artificial organisational boundaries that have prevented some of that work being done. And then at a local level, a real focus on health inequalities, formal agreements in place underpinning work with system partners, and then robust feedback mechanisms. So one of our USPs as the ambulance sector is the data we have, the intelligence that we have on patient populations. So feeding that into neighbourhood and integrated care system conversations. And Simon's talked about the great work that's being done across the southeast to come together with a desire to sort of strategically commission rather than transactionally contract. And there's too much of the latter still happening, which isn't in the best interest of patients, organisations, or the system. And we hope that the 10-year plan provides us with a foundation and an opportunity to transform that, so we can move to a position whereby we're commissioned to deliver the services that we know would be better for our patients.
Thanks, Hannah. And I think, again, going back to what I said before, one of the things we're kind of trying to kind of gauge the centre in is just being realistic about the capability that exists. And we are transferring quite a lot from ICSs to regions, but do regions necessarily have that kind of capability? And particularly kind of when things go wrong, regions can be a long way away from the action, for example. So that's something that we really need to kind of to delve into. Now, clearly, for the ambulance service, as for the rest of the service, we have to balance our desire to do things very differently with our need to recover tomorrow and the next day and the next week. So let's kind of turn a bit more to some of those kind of operational questions. And so I'm just starting with you. Obviously, the whole question of the interface between ambulances and accident emergency departments, the issue of handover delays, it's been really one of the kind of big questions, clearly one of enormous importance to politicians. What do you think we've learnt over the last few years as that issue has come to prominence? We've seen the development of different ways of trying to solve this problem, different targets. What do you think? What do you think we've learnt, Simon?
So I think fundamentally the challenge is for all of us, we're going to have to work out how we move away from sending you an ambulance to see if you need an ambulance. Because there's no doubt that at the moment, all of us still convey far too many people to hospital for a huge variety of reasons. But that starts with, in actual fact, we need to influence and change the model of care so we don't send out as many ambulances to patients. We've now got some of the intel, some of the tools that allow us to make a different disposition for calls. We need to do more of that. So segmenting our calls, diverting them away from an ambulance response, diverting them away from taking them to hospital. Here's a practical real world example. We've got a hub in one of our centres in Ashford, which is actually staffed, I was there a couple of weeks ago, by a GP, mental health nurse, A&E consultant. And I spoke to the A&E consultant when I was there, and he said to me, it's absolutely fantastic, this hub, because I saw a woman in A&E and I sent her home having treated her. She rang the ambulance service back. And because he was in the hub, he was able to intervene and say, you don't actually need to go back to A&E. Here's what I can do for you. And a different disposition was reached. Now, that's the example for me that needs to be scaled up right across the system. If we're ever going to cope with the tide of demand that is inevitably going to grow as time goes on, aging population, etc., we need to develop different models of care. Simply doing the same thing and keeping on doing the same thing will inevitably result in the people who most need us being not served well, but also the people who could be treated differently, not being served well. So the existential challenge for the ambulance services, what we've had has worked hugely well. And I know people really affiliate and are responsive to the ambulance service. But if we carry on with that model for the next 5 years, we will not succeed. That's the challenge for me.
John, do you have anything to add to what Simon said?
Yeah, well, I agree. So we're all working hard on alternatives, safe alternatives for patients, and certainly we've got down here in the southwest low conveyance rates. And there's more we could do and more we are doing. I think the other bit of learning for me as we've gone over the last few years is how do we understand risk at both system level, hospital level, and bring that together as a conversation. So we saw in industrial action for both doctors, but also ambulance services had some industrial action a number of years ago. We also saw through the COVID period how we adjusted some of our risk thresholds. We need to understand that in potential harm for our patients, but also in our culture potentially around litigation. So I think there's something about how do we understand who owns the patient. We mentioned earlier about the sovereignty of organisations. In what you might call peacetime, so outside of those areas, we very much focus on keeping our bit safe. But what we really, I think, need to do is think about the population as a whole. And when it comes to hospital handover delays, when it comes to response times, it's often weighing up one part of a system against another part of what's contributing in the system. And I think if we could get better at doing that, if there's more learning in that space between us, that will make a huge difference to how we go forward with some of these decisions. What Simon's really outlined in terms of alternatives to emergency departments are clinical risk-based decisions about where you draw that, often in the best interest for patients. But we need to rethink some of our understanding of risk across the whole. And often when we're on calls when it's gone difficult, we have a habit, I think, of retrenching into organisations. Whereas if we could get a bit more of that COVID or industrial action mindset, saying, well, actually, we've got the population at a whole. I think some other countries are better at doing this. This is the population, whether that's a neighbourhood, place, or regional level. This is the population you're responsible for. How are we going to do the most for the most in that, rather than what's in the best interest of my individual organisation? I think that will make a big difference to us.
I think that's absolutely fascinating. And when we talk about workforce, we tend to talk about numbers, but actually, we know that an enormous part of why the NHS succeeds or doesn't succeed is to do with, on the one hand, discretionary effort, and on the other hand, people's willingness to take risks, to take judgments, and to take judgments when they know that there might be the possibility that they will have to be answerable for those judgments if they go wrong. And having a workforce that feels sufficiently respected and supported, not only to want to add discretionary effort when it's absolutely necessary, but also be willing to take responsibility, even when that involves risk for them. And I don't think we think deeply enough about the kind of culture we need to create to get that. And this is not marginal. The stats are pretty powerful on the reduction, for example, in discretionary effort that's taken place in the NHS over recent years. It really has a big impact on productivity. Now, Anna, I want to take some of these kind of themes and ask you a question that you and I have discussed a bit in the past, which is that I envy you in many ways. In the Confed, we've got hundreds of members. I can't get them all in a room together. They do very different things. Mental health trust, community trusts, whatever. You've got this small group of chief executives. You can put them all in a room together, although they serve very different geographies. They have very recognizable jobs. There are variations in practice. And also there are variations in perspective. I remember a few months ago, I had a conversation with one ambulance chief executive who spent quite a lot of time telling me about how proud they were of the fact that they had one of the highest hear and treat records in the country. And then I spoke to another chief executive a few weeks later who said, well, you've got to be a bit careful about this hear and treat stuff because, we can measure the impact it's having on the ambulance service or even A&E, but what we don't measure is the impact it's having on other parts of the service as people are referred on to other services. So, we need to be a little bit careful about assuming this is actually reducing demand or making us more productive. So I guess My question for you, Anna, it's been a bit of a tough question for two of your members sitting in on this call, but do you, are you happy with the degree to which A8 is able to get leaders into a room together to look at challenging things like performance variation, to open up differences in perspectives, different kinds of analysis, and for your team of chief executives to really learn from each other by having that kind of quite rigorous kind of conversation with each other?
Yeah, so it's a difficult. So a few things to start with, Matthew. So contextually, we're what ACE is now. We're an ambulance service that represents one part of the system, and everything that we're about and advocating is looking out. So we have been criticised historically, the ambulance service, for looking in, for being too insular. I think there are good and bad reasons for that, but in my role at ACE, supported by the chief executives, we need to be looking out. The only thing to be doing is to be looking out. I think one point, and something else we've talked about, Matthew, is around failure demand. And I think the 10-year plan provides us with an opportunity to address failure demand. The ambulance service ends up picking up a lot of failure demand, and we have the opportunity to sort of straighten things out here to ensure that the patient's getting the right care, the right time, from the right part of the system. And there's something about everybody understanding that the work we're doing with regard to sort of urgent care, community urgent response, what Simon's sort of spoken about, clinical hubs, working at sort of ICB level, is very much about ensuring that we've got an emergency ambulance for the person that needs an emergency ambulance. So it's not kind of one or the other with regards to that clinical space. But so by looking to neighbourhoods, by looking to the local level, we're not turning our back on those emergency calls. And in the same way, I think, my view, working very closely with the chief executive group, I think we're in a strong position because we've got a really diverse mixture. Could do with being more diverse in some ways, but with regard to backgrounds, experience, and we've got examples here with John from the ambulance service, who's worked outside the ambulance service, and then Simon, who's worked within commissioning in acutes, bringing all that together, so to kind of pull that expertise and knowledge, learn from each other, share that best practice, and again move away. And we've talked about it with regard to sort of organisational boundaries at a system level, but knock some of that down. This is about patients primarily, and our people. And I hope that the 10-year plan, we're currently starting work on our 26 to 31 strategy at ACE. People coming behind that, and seeking to do that, and our end ambition is the same. It's about our patients and our people. So we've got Jason Killens is our current chair, chief executive of London Ambulance Service. Now he's been our chair for the last 12 months. Very progressive leadership. Experience in Wales, now experience in London. I think we're in a really strong position to respond in a really sort of proactive, professional and sophisticated way to the 10-year plan, Matthew, and the opportunities that it offers for the ambulance sector to be a fully integrated part of that urgent and emergency care delivery.
Well, thanks, Anna. And I could talk to you three for hours. I've really enjoyed in my time at the Confed getting to know the ambulance service and visiting and speaking to staff at all levels. But we're kind of running out of time, so I'm going to focus on an issue that I know is one that is causing considerable kind of concern, or focus. There's a lot of focus on it, and it's going to grow at the centre, and that is about winter. Because if things go wrong this winter, and who knows, there may even be industrial action in the background, but if things go wrong this winter, it won't be possible for this government to blame its predecessors. It might try, but I suspect the public won't accept that. We know that the recovery in things like, elective waiting lists, there is some recovery, but it's quite fragile. A bad winter could mean that those targets the government have set fall so far away that they kind of lose credibility. And overall in the service, where morale is quite fragile, a bad winter, I think, could pull away a lot of the momentum that's been built up by the 10-year plan, for example. So winter is really, really important, of course, most important of all for the patients and for the public. I'm somebody who kind of resists predictions, because I think, the question is not what do we think the future is going to be, it's what are we going to do to create the future we want. But I'm going to ask you John and Simon, I'll start with you, John, just to tell us how you're feeling about winter as it starts to approach. How confident are you? What are your biggest concerns? And what can the centre still do between now and then to reduce the risks? John first.
Yeah, so hugely important for patients, as you say, Matthew. As we get towards that period, we know that historically ambulance response times, increased ambulance response times, we know are linked back to patient experience and in some clinical conditions to outcome. We had some horrible cases here last year where we had patients waiting for large periods of time, often fallers who might not have had injury but were older parts of the population. So I think we'd all want to focus on what can be better this coming year. I think, um, as ever, we're in the midst of winter planning. We're putting down our initiatives on paper in a plan. Some good learning from last year and previous years, and some innovation. I think the thing we need to do to go further is really push ourselves on over the next few months. We've got a bit of a run in. Um, how robust are those plans? But admit, like when we do either major incident testing or actually clinical scenarios, what you do is you keep pushing people. You throw in new bits. I used to be used to be a paramedic educator for a part of my career. As you get students who are really excelling, what you do is you give them harder and harder. And I think what we need to do is really over the next few months test where can we push those boundaries so that when it comes to reality in a few months' time, as we head into November and December, that we've already rehearsed some of this, and actually we're better at taking those risks together at a system level. We mentioned risk earlier in the podcast, and I think actually that for me is going to be critical. The situation is going to be dynamic. You've mentioned industrial action. Who knows what's going to happen with viral illness or and other things? How do we understand risk between us? And often I find in winter, I've worked lots of winters now in the NHS, we sort of reach a crisis. And we say we've done everything possible. Often we would say that's not true for either a major incident or in an individual clinical scenario. We would try more, and I think it's that we need to be putting into our plans and maybe thinking the unthinkable in terms of what we might do, but actually so that we're ready and we're rehearsed for it more this winter than we have been maybe in previous winters.
Well, thanks. And Simon, there are new risks. It feels to me. I mean, John talked about major incidents. I mean, responsibility for some of this stuff is moving from ICSs to regions. But as I said earlier, if something goes badly wrong in a hospital and you rely on the region is a long way, not just kind of physically, but a long way from, the action that's taking place in the particular place. We know from our own research that the financial pressures on health service means that some of the things that have been put in place to help with the winter pressures have simply been defunded uh, over this year. So there are new risks. So how are you approaching this, Simon?
So I think the first thing to say is that we're probably better prepared. I'm going to start with a positive, and I know that's a bit difficult when you're talking about winter. We're actually working further out of winter, and we're working with the regions, with NHS England centrally to make sure that we've done as much thinking as possible up front, and we've done it together. And I think the focus on working in that way is actually really helpful. And then I'm going to go back to the point I made earlier about devolving autonomy, devolving authority, because I think paradoxically, when you're in the middle of a crisis, central command and control doesn't always work as you think it should, but you can find local solutions. And the leaders that I've got working in Kent, Surrey, Sussex are incredibly creative at working through issues on the ground. And you have to trust that they can do that within a framework, obviously. And then you really have to respect, thirdly, and I will pay tribute to my acute trust colleagues here who've done a stellar job at helping us deliver the 45-minute handover time. You have to really work out that although, again, the public may think all NHS hospitals are equal, they are not. And you really do need the context-specific solutions that local leaders only local leaders can develop. And my job, the board's job, is to back those solutions and to try and be innovative in that space. So my plea would be, don't let's centrally control everything in the middle of a crisis. Let's trust people to come up with those solutions. Let's back them. And let's recognize that, all of our patches have differences that we need to work with.
Well, I think it's a wonderful way to end our conversation, because I think if that's true of your ambulance service, I think it's equally true of all parts of the health service, actually. We are simply not going to thrive in the future unless we can create a kind of culture of devolution, empowerment, and trust. Thank you so much, Anna, Simon, and John, for really a fascinating conversation. And listeners, if you have an exciting or innovative program of work you'd like to tell us about, please do. You might end up talking with me on Health on the Line. Just contact healthcommsplus@nhsconfed.org. Goodbye.
You've been listening to Health on the Line, produced by Health Comms Plus. Health Comms Plus is a highly effective, innovative and creative communications agency brought to you by the NHS Confederation. We offer a creative, professional and cost-effective service for NHS and public sector organisations across the UK. Any profit we make is reinvested in the support we provide to NHS organisations and wider health and care systems.